Good morning, everybody. It's first day of fall, September 22nd, 22. We have our PACU resident Sam speaking with us today with our topic, malignant hyperthermia. If everybody on Zoom can make sure that you're on mute, that would be great. I can hide these meeting controls. Okay, we'll let you take it away. Zoom on in, right?
Hey everyone, I hope you all can hear me. My name's Sam, everyone here as well.
Just make sure, so if your shoulder hits the, there you go. You're fine. I just wanted you to be aware that it is. I can pull it over for you. Okay.
All right, cool. So my topic is malignant hyperthermia. Thanks, Adam. Yeah, appreciate it. So just to start off a little bit about me. So I did my undergrad training at Bob Jones University. Yes, it is a real college. Everyone always asks me the question saying, is this actually a real place? Yes, it's in Greenville, South Carolina. I did I got my bachelor's in biology with a chemistry minor. After finishing there, I had no idea what I wanted to do, just like every college student. So I moved back home, which is here, Detroit, Michigan for me, Sterling Heights, Michigan, and started looking for work. I initially thought I wanted to do research. Didn't really like it. My uncle was working at Quicken Loans at the time, so got a job there. Worked there for roughly 3 years as a banker. Did not enjoy that as much as I thought I would. And then towards the end of those 3 years, I really kind of started feeling like, man, you know, I really went into, I went to college initially because I really enjoyed biology. I really enjoyed chemistry. Let me re-explore that avenue. So I applied to do a master's degree in basic medical science with like an engineering emphasis at Wayne State. I did that for a year and a half, realized I enjoyed the basic medical sciences. I started talking to some of the faculty there, and then I started thinking about pursuing medicine. A lot of the faculty there encouraged me to do that. While I was there, I was also working at Beaumont as a pharmacy tech. So I did that for a couple of years as well. Continued that throughout medical school. I did medical school at Michigan State University, College of Osteopathic Medicine. I was very limited in terms of location because my family, my home base was in the Sterling Heights area. I was lucky enough that MSUCOM had a campus right in Macomb. So it was a 10-minute drive for me, and I did not have to go anywhere else. I think I only went to East Lansing twice, and that was the white coat ceremony and graduation. So it was very, very nice. So again, it's a little bit about me. For me, family is really important. So the two folks standing in the back are my parents. It's my mom, my dad. So to your left, that is my wife. The jaundice baby that I'm holding is our 1-month-old. In that picture, it was April, so we're on Easter. She's 1 month. On the right side, that's my brother and his wife. That is their daughter. She was born a month and a half before our daughter was born. And then the little girl that my wife is holding is my niece. So it's my brother and sister-in-law's daughter. This is us on July 4th. That's my brother-in-law, mother-in-law, my wife, and then daughter, a little bit older, still sleepy though. She doesn't do that often. I actually had to wake up with her today at 2 o'clock, spent an hour with her trying to get her to go back to sleep, which didn't work. And then mom steps in and of course she falls asleep in 5 minutes. So this is us just on some walks. She loves, her name's Molly. Molly, yep. This was her, the picture on the right was her 2 days ago. She got up at 5 o'clock, would not go back to sleep. So my wife turned on her some YouTube channel, so she's just chilling there watching that. So usually it's my free time is spent hanging out with my family, hanging out with my daughter, and then funny picture hobbies. This is as every resident can tell you, sleeping is probably the top on the list of hobbies. She did not. I promise she did not fall.
Good.
Yeah. I was partially awake during this this picture, so she did not fall. But honestly, other hobbies that I try to do, I like fishing, I like hunting. Those are things that I do with my dad when I can. Obviously, a little bit more limited now, but again, I love spending time with my family when I can. All right, so we can get into the topic of malignant hyperthermia. So we're going to discuss clinical relevance, pathophys, organ system manifestations that you'll see, PACU management. We'll highlight the Stanford guide, the emergency manual. It does highlight a lot of what happens intra-op, but some of the steps can obviously be applied to PACU. And we'll also give a differential diagnosis in terms of what other disease states may present similar to malignant hyperthermia, and then go over a summary. So clinical relevance, again, this is an autosomal dominant disorder with variable penetration. We always ask in pre-op, family history of any problems with anesthesia. So we're looking for anybody who may have had, a triggering event in terms of, their family history. Or an exercise-induced rhabdomyolysis, right? Something like that can occur in the ED, the patient shows up. But those things can also point towards malignant hyperthermia. The incidence is roughly 1 in 12,000 in pediatric patients, 1 in 40,000 in adult patients. The reason that the incidence is a little bit higher in pediatric patients is because they're essentially receiving anesthetics for the first time. So we pick it up when they're younger, if that's the case. Mortality is usually, again, 5 to 10%, but that's because we're good at treating it when we initially see it. Untreated, 70 to 80%, so quite high. The one thing to keep in mind is the anesthetics themselves can be inconsistent in terms of triggering malignant hyperthermia. So a patient may actually have a defect in their, again, we'll talk about the receptors, but can have a defect in the receptor and can be exposed to succinylcholine, could be exposed to volatile agents, and still not actually have a triggering event. Does not mean that later on down the road, they don't have a triggering event. But again, it's something to kind of keep in mind. Just because they've had an anesthesia in the past and didn't have an event does not mean that they cannot have one in the future. And again, onset can be acute, so we can see this intra-op, or it could be delayed and we see it in PACU. Triggers for MH include succinylcholine and your volatile anesthetics. Those are your DES, your ISO, your SIVO, fluorine. And then the drugs to kind of keep in mind that don't trigger MH, opiates, benzodiazepines, ketamine, prope, non-depolarizing muscle blockers, local anesthetic, and nitrous. Now, I will say, if we know a patient has MH, we take precautions in the back in terms of making sure we remove all the vaporizers from the OR, remove any triggering agents, and then we flush the actual anesthesia machine to make sure that the circuit is completely clean of any volatile anesthetic. Now, if that's not done, you could see a triggering event in PACU, even though we may have used non-triggering medications. So just something to keep in mind. So again, pathophysiology, it's a defect in the calcium releasing channel. The most common defect is the ranitidine receptor. And again, it's specifically to the ranitidine receptor 1. So it's located in skeletal muscles. Or the ranitidine receptor, the second one is located in cardiac muscles. That one is not affected by MH, okay? The two genes are actually located on separate locations, and that's a good thing because if you had an MH triggering event that affected the cardiac cells, you would have sustained contraction, and then you would have no perfusion whatsoever. So it's a good thing that it's located on 2 separate genes. Essentially what happens is, again, I'll kind of show some pictures, but the calcium, you have a huge influx of calcium to the sarcoplasm, and you get the sustained muscle contraction when exposed to triggering agents. So again, I do very well. I'm like a picture person. I like seeing something and then explained it to me rather than just having bullet points. So on your right, that is, again, kind of like a muscle cell fiber. So you get that depolarization at the neuromuscular junction off over here. Again, that propagates all the way down, and then I wonder if I can, oh, I can slide here, perfect. So propagates all the way down, and then this is your dihydropyridine receptors. It activates that receptor. Now you can have a defect in the dihydropyridine or in the ranitidine receptor. Ranitidine receptor is going to be this one down here. But essentially, normally what you'll have is again, propagation, activation of the dihydropyridine receptor, which then, again, through conformational changes, activates the ranitidine receptor. And then the ranitidine receptor opens, and then you get this efflux of calcium right into the sarcoplasm. Now, sarcoplasm contains all your muscle fibers, right? It's got your actin and your myosin. Calcium, again, is this, it's an activating agent. And if you look over to the left right here, so this essentially happens as calcium comes in, it'll bind to the troponin. Then the troponin will essentially trigger and release and pull off the tropomyosin. The tropomyosin is this blue filament right here. And then what that does is it exposes the myosin binding sites on the actin. Okay, so myosin is usually the one that's it's not active in terms of moving, it's the one that's contracting. So it'll pull those actin filaments together. And again, normally this is a normal process. It'll pull once the contraction is triggered. Once you actually relax, calcium will dissociate from the troponin. It will go, and then it will be it'll go through a reuptake process by the calcium ATPase, and then get thrown back into the sarcoplasmic reticulum lumen, where it is stored. And then the event is essentially reverses itself. So then the troponin is activated again. Tropomyosin comes back down. It blocks the myosin binding sites, and then you get relaxation, and then that kind of ends the contractile, essentially the contraction motion. Now, the difference is when you have a defect. So if you have more than hyperthermia, or not more than hyperthermia, but if you have a defect in one of these receptors, whether it's the dihydropyridine constantly staying active and keeping the ranitidine receptor open, or there's an actual defect in the ranitidine receptor, in which it just constantly stays open and doesn't close, the triggering of the anesthetic will essentially leave it in the stuck open state. So then you'll have constant efflux of calcium, and then you'll have constant, again, binding contraction of the muscle itself. Now with that, again, you see this you'll see hypermetabolism, but you'll see this rigidity. So you get this constant contraction. You're constantly burning through, I don't have it pictured here, but the actual process of the myosin binding and pulling requires energy, and our energy source is through ATP. So you'll burn through a ton of ATP maintaining that contraction. While in the meantime, you also have the calcium ATPase trying to pump calcium back and burning through ATP at the same time. So you get this prolonged contraction, and most of you know from exercising that as you're exercising, the way that your body kind of deals with it is producing heat. So again, you'll produce heat. You'll see this hypermetabolism. You'll see significant contraction. I'll kind of talk about it a little bit later as well. But as you're burning through ATP, your body says, okay, we're not able to produce enough energy from aerobic. Aerobic means it'll go through anaerobic phase. You'll start producing lactate. And we'll kind of discuss, again, these huge shifts that you'll start getting in terms of electrolytes. But again, you get heat production, you get hypoxia, you get death, cell death. Again, you'll get release of myoglobin from, again, cellular death itself. And again, one of the things to kind of keep in mind is anytime you get into a phase where your body has a higher metabolic demand, you're producing more carbon dioxide. As you're producing more carbon dioxide, if the body isn't making adequate adjustments, you can get into electrolyte abnormalities, you can get into, again, acid-base issues. So essentially what we're seeing here is, this is just, again, not significant. It's not pointing to malignant hyperthermia itself, but essentially the process and what tends to happen. So CO2 is dumped into the bloodstream. There's a buffer system within your red blood cells that allows you to kind of buffer and carry CO2 to the lungs where it can be exhaled. But the problem is when you're getting high concentrations of CO2 dumped into the bloodstream, it is pushed off to the right. So if you see the far right, you start producing protons. So you get a huge increase in terms of proton production. And again, your body has means of adjusting and compensating, but the way it does that is by shifting protons intracellularly, which I don't have a picture of, and shifting potassium extracellularly. So you'll get hyperkalemia. That's one of the biggest things that you'll see, right? You can see EKG changes, you can see arrhythmias on the monitors. So again, hyperkalemia, you get a hypermetabolic, and again, it's all due to this hypermetabolic component that occurs with malignant hyperthermia. So organ system manifestation. So what would you see in terms of what happens to the organ system? So you'll see tachycardia, and again, this is the body's compensatory mechanism in trying to increase the oxygen supply to those cells that are saying we need more oxygen, also trying to kind of move carbon dioxide out. In pediatric patients, it can manifest as sudden cardiac arrest just because they don't have the same compensatory mechanisms that adults do. And again, we kind of discussed that you could see, again, some EKG changes. You could see peak T waves if we start seeing this hyperkalemia, onset. Other things you could see PVCs, ventricular tachycardia, or fibrillation. Respiratory wise, present as hypoxemia, hypercarbia, tachypnea, and increased end tidal, which for us, intra-op is the most sensitive indicator, right? We'll start seeing this increase in end tidal over 5 to 10 minutes. It doesn't respond to me increasing my minute ventilation on the vent. It doesn't respond to me increasing the respiratory rate on the vent. It just continues to rise. Now here in PACU, the one thing you'll see is tachypnea, right? So your body's way of trying to get rid of those protons is, again, to try to breathe off more of that carbon dioxide. So you'll see an increase in respiratory rates. Other things you'll see, mainly airway issues, masseter muscle spasms. So again, the masseter muscles may become really, really tense and tight. This will probably go first in terms of your muscle contraction. Other things, renal failure. Again, this is secondary to rhabdo. Rhabdo caused by, again, the cell lysis and you releasing myoglobin into the bloodstream. Metabolic issues. Again, we kind of discussed the hypermetabolic issue in terms of where you start getting acidotic. So you'll get respiratory acidosis. And again, we're always focused on the hyperthermia aspect of this, but this is usually a delayed late sign. But again, you will see a profound body temperature increase. Hematologic things to think about is also disseminated intravascular coagulopathy can occur. And again, this is secondary to, you will have calcium release intracellularly or extracellularly, sorry. Nervous system, you can get cerebral edema, again, caused by metabolic changes. And then musculoskeletal, you can see muscle rigidity and rhabdo. Now, things to kind of keep in mind, patients with pulmonary hypertension and any patients with kind of neurological manifestations, a little more concerning in them because when you have this increase in carbon dioxide, you get pulmonary vascular resistance, you get an increase in pulmonary vascular resistance, which means the pulmonary hypertension will worsen. So again, making sure that these patients are oxygenated appropriately. And again, same thing with patients with kind of neurologic manifestations, increased carbon dioxide, increased cerebral blood flow. If a patient just had a recent craniotomy, herniation, if the ICP is going whack. So just those two subsets of surgeries or patients are ones to kind of keep in mind. So PACU management, I kind of jotted just a few things. You can either get a BBG or an ABG, but things that we're looking at when we're getting BBG, you're looking at the pH, so you're expecting acidosis in this case. You're looking at potassium, expect hyperkalemia. We're also looking again at the glucose. You're looking at the carbon dioxide. Now, one thing that we can do, obviously intra-op, is we can measure the AA gradient so we can see if it's actually correlating with in terms of what our machine's telling us. But yes, you will see an increase in the carbon dioxide. Other things, you would get a BMP, you're looking at other electrolytes, you're also looking at the creatinine, making sure it's not worsening, because again, you are having that myoglobin that can potentially will injure the nephrons. And then coags, again, we're looking for DIC at this point, creatinine phosphokinase, just making sure that you're going to see an increase in this, but also making sure that we're giving adequate volume to kind of level out and diminish the amount of kidney injury that we're getting. Lactate as well, and again, I kind of said anaerobic metabolism, so you expect the lactate to increase. But again, we're getting all of these, so we get a baseline, we know what to do, we know what to treat. And I kind of just took some snapshots of the emergency manual that's sent out by Stanford Anesthesia. So again, these are kind of signs, early signs that we would see. And again, I kind of mentioned tachypnea, tachycardia. You will not see the increase on tidal, unfortunately, just because we don't have any way of monitoring it here. And then we already discussed some of the late signs. This, again, doesn't really apply to you up until we get to number 5, right? Because we can't really do anything in terms of increasing our flows. I mean, essentially put a face mask on or a nasal cannula and increase flows, which would help. But we're not able to change minute ventilation at all. So we'll jump down to 5 where it says, essentially administering dantrolene or Ryanodex. So previously, from my understanding, was that we had dantrolene here. Dantrolene, unfortunately, requires a lot in terms of trying to reconstitute it. So you can see here, it's 20 milligrams of dantrolene in a 60 ml vial, and you would have to reconstitute roughly 9 vials for 175 milligrams for a 70 kilogram patient. I'm sure you're all aware, it's very rare that we have 70 kilogram patients here. And essentially, a lot of the patients that we treat in the intra-op would require way more than the 9 vials. Luckily, now we've started using Ryanodex. So this comes in a 250 milligram formulation, and you only have to reconstitute it in a 5 ml vial. So a 70 kilogram person getting 175 milligrams would be 3.5 mLs. A lot less work in terms of trying to have somebody reconstitute and also inject the dantrolene at the same time. But again, if you're suspecting malignant hyperthermia, you're rapidly giving Ryanodex, and then you're continuing to give, you may need 10 milligram per kilogram dose. And again, it'll be right off the bat, 2.5 milligrams per kilograms. We kind of discussed, again, you would see hyperkalemia, again, you see EKG changes, you would see some changes on the monitor, give calcium gluconate or chloride to stabilize the cardiac cells. Then you would treat with how we normally treat, so give insulin with D50 amp. And then the other thing to keep in mind is, so the sodium bicarb, I would kind of do the focus on that on base access. So if you have greater than 8 milliequivalents, that's when I would start giving sodium bicarb. It doesn't really outline that here, but that's what I was reading when I was doing this lecture. And again, these arrhythmias are going to be secondary to hyperkalemia. So the biggest push is to try to move the potassium intracellularly. In terms of temperature management, actively cool the patient, ice packs, cold saline through the IV. And again, we kind of discussed sending those labs out, things that we're looking for when we're sending those labs out. And then also secondary, things that are important, making sure we get a Foley catheter in, monitoring urine output. So the goal right there is 1 to 2 milliliters per kilogram per hour. We can definitely give IV fluids, definitely give diuretics. You don't want to hypoperfuse the kidneys, further damage them. So making sure that we give adequate IV fluids and diuretics. And then the other thing is you may we may give dantrolene right off the bat. You start seeing response in terms of patient's respiratory rate is starting to improve, but there's always the possibility of it recurring. So in patients who have MH, you will continue the 1 milligram per kilogram every 4 to 6 hours. So you'll continue the treatment. You're not going to just stop it, but by that time they'll be up in the ICU. But again, just to keep in mind that it will continue, they will continue to have these triggering episodes if we do not continue to treat it. And again, I kind of discussed some of this stuff. So Ryanodex, I didn't really cover this, but I'll go back to the slide where we had the actual image. So you look over here, dantrolene actually works on the ryanodine receptor. So it does not work on the dihydropyridine receptor up top, okay? There may be a defect up here, but we're not really concerned about that. We're concerned about this receptor because it is the one that's initiating the calcium efflux. So we can get this to close, which is what dantrolene does, changes conformation, puts it in a closed position. You no longer get the efflux of calcium, muscles can relax. You, again, decrease the hypermetabolic drive and you allow the muscles to essentially relax. Things to kind of do in PACU, usually patients, again, I've asked a few of my attendings because I keep getting different responses, but I think the overall thought is to re-intubate the patient. The thought process is because obviously with the increased tachypnea, you get increased work of breathing, so you get fatigue and to the point where they are not taking adequate, they're not breathing adequately enough. But then you also have to think about not just exhaustion, but again, in terms of making sure that they're receiving appropriate oxygenation too. When we intubate, we can obviously deliver higher flows, higher oxygenation content. So that's kind of been the thought process. Obtain second set of IVs, A-line obviously to get labs, but also to monitor any hemodynamic shifts or changes. We also discussed, again, placing a Foley catheter. We also discussed electrolyte management in terms of potassium and sodium, and then temperature management. We also discussed that in the previous slide. So I believe it was on Wednesday, I tried to go around and find where the malignant hyperthermia box was. So I asked around. It is in the front desk, the OR front desk. If you guys go there, right where the CRNA sits, right above them is the malignant hyperthermia box. That is the closest one that's stored here. And then I tried to figure out what the contents of it were. And of course, they don't put it on the outside of the box. So I had to go to policy stat. So things that are located in the box itself, you've got your calcium chloride, lidocaine, your Ryanodex. And again, you've got 3 vials in there. So enough to make quite a bit. Your sodium bicarb sterile water. There's like quite a bit of syringes and needles in there. I didn't think it was necessary to include all of that, but they do have all the supplies that you will need to reconstitute and draw up your medications. So other things in terms of differential diagnosis. So things that can kind of present similar to malignant hyperthermia. So we think of sepsis. Easier ways to kind of differentiate this. If it's early on, you could see signs of, again, infection, hypotension, constant requirement of fluid boluses, constant requirement of pressors. That would kind of point you more towards a sepsis picture versus a malignant hyperthermia picture. You'll see the increase in temperature regardless. But in these cases, do not delay antibiotics. There is a thought process of, hey, can we get inflammatory markers? Sure, you can, but anytime patient is post-op, you're always going to see a rise in inflammatory markers. So they're not specific to sepsis, unless the patient obviously comes in with an infection. The other thing to keep on your differential is neuroleptic malignant syndrome. So this one is really looks a lot like malignant hyperthermia because you get the muscle rigidity, you get the increase in the creatine phosphokinase. So again, can present like a similar picture. You'll get the hyperthermia, but the one thing that you can use to differentiate malignant hyperthermia from NMS is you could assess for clonus in the lower extremities. The other thing you could do is the Babinski reflex. So you would get this, essentially, you'd get an extension of the big toe and kind of fanning of the toes instead of the usual flexion that you would get. So that would allow you to differentiate, again, NMS from malignant hyperthermia. And then the other thing is thyroid storm. So again, patients in this scenario, and NMS, another thing to keep in mind, our patients are antipsychotics. So if there aren't any antipsychotics, put that high in your differential. For thyroid storm, again, any patient that has had any issues in terms of hyperthyroidism, get TSH, T3, T4 to see if their levels are off. With thyroid storm, the usual presenting arrhythmia that you would see is you get tachycardia, but then you would also get AFib from that. And then again, you'd see like things like agitation, altered level of consciousness, but you could see that in the other ones as well. So quickly, just covering summary. If you do suspect malignant hyperthermia, notify PACU faculty or resident immediately. Obtain the MH box and kind of discuss where that's located. Administer Ranadex, send labs, and then in the meantime, correct electrolytes based on those labs. And then the other thing is obviously making sure we can control the patient temperature. These are my references. Again, some of the stuff was from the U of M policy stat, and I also used Morgan and McHale's clinical anesthesiology to kind of go over the pathophys of hypothermia. And then these are some of the articles that Tricia had sent me. That is it. Do you have any questions? So we've replaced dantrolene with Ryanodex. So we're going to use, so it's already been replaced. Use the Ryanodex. Dantrolene is no longer used here. Just because the time and effort it takes to reconstitute dantrolene was more significant. So that's why they had transitioned over to Ryanodex. It's the same, it works the same mechanism. So the picture that I showed you earlier on, right here, so dantrolene and Ryanodex work at the same mechanism, and just the Ryanodex is a more concentrated solution in itself. So we don't have to give as much.
Do you guys give it, or we can give it?
That I am not sure. I don't know what the policy is. I would. Okay.
I don't think there is a policy against us giving it. Like if an ACLS, like it's a code situation, so we're allowed to give it. I think in this situation, pharmacy is right around the corner. We grab that, help administer, reconstitute, whatever. Be a good effort for that.
Yeah, and I wouldn't.
No,
Yeah, and I wouldn't delay giving it if you're actually starting to see, changes on your monitors in terms of oxygenation, in terms of changes on, the EKG. I wouldn't delay. If you can give it, go ahead and give it, especially if you don't see any faculty or resident around you.
What do you see when you stop giving Ryanodex? What are you looking for?
So you're looking for improvement in terms of respiratory mechanics, right? So the tachypnea should start improving, just because you're not dumping as much carbon dioxide now into the bloodstream. But you will not see a quick improvement in terms of EKG changes. So you should still treat hyperkalemia right off the bat. But essentially improvement in respiratory mechanics would be your first thing that we see. Since it is the first thing that we see back there in terms of increasing M titling.
There's really no limit how much you give it to see the changes.
So you'll continue to give based on, so you'll give an initial 3.5, right? So that's the 3.5 mLs for a 70 kilogram patient. If you're seeing improvement, you'd wait. Hopefully by that time you have a PACU faculty or a resident around to kind of assess. But then if you're starting to see, again, kind of changes back, you'll continue to give. And again, I kind of highlighted that they will need an infusion of roughly 1 milligram per kilogram within that 24 hours. So they'll continue the infusion for 24 hours. just because you can have a recurrence in terms of, MH can reoccur because you'll get this, the channel itself will open up again. So you'll continue an infusion. But right off the bat, that's what you're doing is you're pushing a higher dose.
Isn't there an MH hotline too?
There is an MH hotline. It's like on the actual, for some reason it cut out when I was trying to post or take the picture and actually post it on there. But you can call that hotline, but I would not call the hotline and then try to do this. I would treat the patient first, then call the hotline, or have somebody else call the hotline while you're treating the patient.
I have a question. I recently have a septic patient in Iran. So the patient went to ICU, right? I guess we treated her with doses, 30 people. In which, how do I differentiate them not really going to really have hyperthermia because the temperature is going up and up, and you know what I mean? So
Right.
I got part, should I start cooling or like that?
Right. So again, the thing, it's difficult to differentiate sepsis because again, the inflammatory markers post-surgery are going to be high. But the one thing to keep in mind is the significant hypotension that you're seeing. That is pointing towards a septic picture. You will not get this hypotensive picture right off the bat with malignant hypothermia. You get the tachycardia, but you'll also get the tachycardia with sepsis. So yeah, you won't see this, again, quick hypotension right off the bat that you would with sepsis.
Can I the screening questions that we do? Is there anything else we do or that you've read?
So there is
Preventative.
genetic, right? We could do genetic testing. The reason I didn't include that is because we usually don't just jump right off the bat and get it. If the patient does say they have a significant past medical, not past medical history, but a family history that's positive, again, we're a little more cautious. So I think depending on the surgery itself, if it's a little bit more emergent or urgent, we would obviously treat them like they have MH and make sure that, we've gotten rid of the vaporizers, any triggering agents in the back and still proceed with surgery. But genetic testing is the other thing that we would look for to see if there's any defect in terms of the genetic encoding for those receptors. I did not include that, I apologize, but that's another thing that we would do for patients with MH.
Last question, sorry.
No, you're fine.
For the anesthetics, so you said that more volatile, the other volatile anesthesia and this can you give us specific
Yeah, so there's only 3 main ones that we use here. That is desflurane, isoflurane, and sevoflurane. So anything that ends with fluorine is going to be your volatile anesthetics. If anybody comes out, if any resident CRNA attending comes out here and says we did an endotracheal tube intubation, we ran half a mac of gas. If they say gas at all, assume it's a volatile anesthetic. We don't tend to use nitrous here. We don't tend to use it often just because it's harmful to the environment. But if they say we ran gas, that's going to be a volatile anesthetic. Yep.
I was looking to see questions on the chat.
Oh yeah, sorry about
Sorry,
that.
Sarah, we didn't repeat questions, but I think that's a.
Do they prescribe chill pills?
What are you talking about, Crystal?
I don't think it's a way to cool the body off. Is it?
Yeah. Any other questions to throw out on the chat? Put them up now or I think it was Joe. All right, got it. Thank
You're
you.
welcome.
All right,
Thank
well
you.
done. We appreciate it.
Yeah,
All your time and effort.
no problem.
Tori was on here. Serena. Okay, let me try to stop the recording.